Thank you, Rebecca, for really a testimony, really, for why we are all here and doing this work. Lovely. So here we are for our last panel of the day. Is that, yep? Oh. No? It's there, but it's not. Lauren? There, okay. Hi. So thank you for being with us to the very end. Our last panel today is going to explore the integration of financing for medical and social services, something near and dear to my heart. I am a social worker, and I have been working for 42 years to hear some of the lines that was put in this recommendation. A key finding of the report is that the reform is needed on how resources for care are provided near the end of life are organized. Our current financial incentives encourage a reliance on acute care settings that are often costly, poorly suited to the needs and goals and preferences of people and their family, some things we've been hearing all day. This over-medicalization of care is one of the reasons that the United States spends so much money on medical and end-of-life care. I chose to highlight the chart behind me, which essentially shares the recent analysis of Bradley and colleagues, which you can find in the committee report, in which they attribute the high rate of healthcare spending and our inferior healthcare outcomes in the United States relative to other developing countries to really demonstrate that the lack of integration of health and social support programs are what drives this. In fact, many of the OECD countries that we see up there actually spend more on health and social services combined than we do here in the United States. This analysis is relevant to the IOM Committee's findings because from a systems perspective, fragmented, unwanted, and unnecessary acute care services, which are currently the default or glide path of our system, are extremely costly, and they don't deliver the care that people and their families want. In addition, what we also know, and the committee found, is that these perverse financial incentives are promoting frequent transfers from hospitals to nursing homes, and they can actually cause significant harm. Yet many of the practical social services that would allow people near the end of life to live safely and comfortably at home, where most people actually prefer to be, are not easily arranged or paid for. The committee also found that hospice, palliative care models, and other models that integrate health and social services, when properly implemented, may in fact improve quality of care, reduce the use of expensive services, such as 911 calls and emergency room services, and potentially help stabilize the healthcare costs for people near the end of life. For all these reasons and more, I'm delighted to introduce our panel, who will share their comments on the integration of financing for medical and social services. And so I will introduce them, and then we will hear them in the order that I introduce them. And I would appreciate it if you take a look at their bios in your packets. I'm just going to do a short introduction. First, we will be hearing from Peggy Maguire, who's the Senior Vice President in Corporate Accountability and Chief of Staff of Cambia Solutions. Among her many activities, she serves as the chair of the National Advisory Board of Cambia and Palliative Care Center of Excellence at the University of Washington School of Medicine. Next, we'll hear from David Stevenson, who's Associate Professor of Department of Health at Vanderbilt University School of Medicine. His primary research interests are long-term care and end-of-life care. He was co-author with Hayden Hauskamp on the committee's commission paper on financing care at the end of life and the implications for potential reforms. And last, but certainly not least, is Bruce Vladeck, a senior advisor of Nexera Inc., a wholly owned consulting subsidiary of the Greater New York Hospital Association. He has a long and varied career in health policy, and I know many of you know him as the former administrator of HCFA. I've had the good fortune of knowing him since he was the assistant commissioner of the New Jersey Department of Health, which actually brought us the DRGs. So with that, I'd like us to hear from Peggy.
Thank you. It's just great to be here with all of you today and to have listened, let's see which way is it going, there we go, to have listened to the recommendations and the discussion about the recommendations. I thought today, well, let me tell you a little bit about Cambia Health Solutions. We are a total health solutions company headquartered in Portland, Oregon. We have a portfolio approach. We have 25 companies within our portfolio of health solutions. 7 of those are health insurance companies. And we also have a corporate foundation that I'm privileged to lead. My talk today, I was going to remind you all that palliative care is personal, but now I'll just pile on to what Rebecca said. You know, in the corporate world, we often hear about ROI, and we hear, oh, it's not personal, it's just business. But those of us who have spent any time in the corporate world understand just how backward that statement is. Because making it personal is what drives our success. It's what connects us to our employees and to our consumers. And I can't think of an industry where making it personal is more important than healthcare. Indulge me. Healthcare is personal to all of us. And I show you this picture because it's the picture of the people I love most in the world, my family. And what strikes me about this picture is a couple of things. One, how happy we look. We had just been whale watching near the San Juan Islands in the Puget Sound. And the second thing about this picture is that my daughter Franny, the one on the far left, the one who has loved orcas since she was a toddler and who organized this particular family excursion, she's about the same age that I was when my dad was diagnosed with terminal cancer. He had a very similar experience to Rebecca's brother. And that was more than 25 years ago, but it turned my life upside down, and I still remember it as if it were yesterday. My family, my siblings, my mom and I were caught completely off guard by my dad's diagnosis, and we were quite ill-prepared for what would come next. In our shock, we did everything we could to fight the disease. We didn't know about palliative care, and we didn't ask for it. My dad's quality of life suffered greatly. Chemotherapy ravaged his body, leaving him weak, exhausted, and hospitalized. In retrospect, we know now that treatment was probably futile. He died in the hospital just a few short months after his diagnosis. I was left feeling like I'd been run over by a high-speed train. Although we had done everything we could to help the person we loved most in the world, we were left feeling guilty and wondering, what if? And so in evaluating the recommendations in the IOM report, I asked myself, had they been implemented, would they have helped me and my family navigate that situation? And I'm certain that they would have. We are all in this room professionals working in a very important and challenging field. And for a moment, I ask you to take off your professional hat and think about this not as a policy issue, not as a reimbursement issue, but as a very personal issue. How many of you in this room have had your own experience dealing with a family member or a friend in serious illness? Ask yourself, would the recommendations in the report have helped them? At Cambia, we're reminded every day that what we are doing is personal. Our cause, and the cause that guides every one of our companies, is to serve as a catalyst to transform healthcare. We are trying to create a more person-focused and economically sustainable system. This photo hangs outside of our CEO's office, and I walk by it every day. It's not a stock photo. The woman in the center of the photo in the orange shirt is one of our foundation grantees. Her name is Carolyn Nystrom. She runs the Hospice and Palliative Care Center of Wood Valley, Idaho. With her is Loie in the bed who has ALS, which is a very difficult condition to manage outside the hospital setting. But thanks to Carolyn and her volunteers, Loie was able to stay in her home as she wished surrounded by her family and her pets. And what strikes me about this photo is that it's not really about someone dying. It's about laughter, and it's about life. If you look closely, you'll see that even the dog is smiling. This photograph is a very real reminder that we are in the business of changing the way that people experience healthcare. We are putting their needs first and trying to make sure that the care they receive is consistent with their individual values, goals, and preferences. And in order to do this, in order to treat the whole person and not just the whole patient or a body part, we need to think about what they need from both a medical and a psychosocial lens. We agree with the IOM report that more efforts should be made to integrate medical and social services. At a gut level, this recommendation makes intuitive sense to me, but it really, I think, is one of the most understudied aspects of medicine, and there have traditionally been tremendous silos between health services and social services. As we saw from the chart, it doesn't have to be that way. Diane Meyer, who was another member of the committee and is the director of the Center to Advance Palliative Care, shared a story with me that I'd like to repeat to you. It's about a tuck-in service available in London. And as the story goes, Diane went to London to pay her last respects to one of the key pioneers of palliative care in the UK, Dame Cicely Saunders, about 6 months before she died of cancer. She lived in one of those classic English row houses with 1 or 2 rooms on each floor and steep steps between them. She had bone cancer, and a lot of pain in her hips, her back, and her legs made it difficult for her to get around, even with the Oxycontin she was taking around the clock for pain. Nonetheless, she was able to stay independent, living alone and in her home until the last couple of weeks of her life because of the tuck-in service. Every evening at 8 p.m., an aide would come and slowly escort her up 2 flights of stairs. That aide would help her bathe and get into bed, and she would clean up the kitchen and leave for the night. In the morning, another aide would arrive and help her get dressed, washed up, and back down the stairs. She would fix breakfast and set her up for the day with her books and her cell phone and her reading lamp. Later, a Meals on Wheels service delivered a hot dinner every evening. If any of these 3 individuals were concerned, they could contact her primary care provider, who managed her care by phone and occasionally by home visits. None of these services required an RN, a licensed social worker, or a doctor, and they were all paid for by the National Health Service. At the end, when she was unable to get down the steps with assistance, she was admitted to St. Christopher's Hospice, which she had founded for the last few weeks of her life. This story provides hope and illustrates what is possible. I think it's complicated. I think there is no silver bullet here, but there are many solutions that should be tried and tested to eliminate silos and provide more integrated care. I think that community health workers may be part of the solution. They are trusted members of the communities they serve, and they can link people to necessary social services. The Cambia Health Foundation recently funded a grant to support the Oregon Community Health Workers Consortium and to increase the competency and training among community health workers. We also funded a grant to an organization called Familias en Acción, which works to empower patient navigators in the Latino community. When we created, I'm going to skip this one because we talked about it a lot, but when we created the Cambia Health Foundation back in 2007, we chose palliative care as the signature program of our foundation, which we call Sojourns, for 2 reasons. One, like me, many of our leaders had experienced serious illness in their own families, and the topic inspired us on a very personal level. We knew it could be better, and we thought it was our obligation to make it so. Second, palliative care represents the type of person-focused care that we'd like to see become the norm for the entire healthcare continuum. Since 2007, our foundation has worked with and collaborated with many innovators, and we've invested more than $20 million in workforce development programs and initiatives. In 2011, we conducted a national survey on American attitudes and expectations and awareness of palliative care. We really wanted to take the conversation away from the death panel political rhetoric and into figuring out what people and families really wanted and needed. We found that 71% of the people we surveyed had never heard the term palliative care, and they didn't know what it was. However, after our pollster explained the term, 97% of them agreed that it is important for patients and families to be educated about palliative care and end-of-life care options available to them, along with curative treatment. Leveraging our learning from that survey, we funded 2 public awareness campaigns. One was the Get Palliative Care project with CAPSI, and the other was the Conversation Project founded by Ellen Goodman. We also decided to expand our Sojourn Scholarship Program to invest in emerging palliative care leaders and scholars across the country. On an annual basis, we award up to 10 nurses and doctors $1.8 million to strengthen their leadership and to implement groundbreaking projects that would advance the field. So I invite you, if you know anyone who has a proposal to integrate social and medical services, invite them to apply for a Sojourn Scholar Leadership Grant. Building on our foundation work, am I over time? Yes. Okay. Let me say this quickly. Building on our foundation work, we also have created what Fierce Payer has called the most comprehensive health benefit program in the country. And sure, we borrowed from Aetna. We looked at Aetna's program, and we looked at other programs at Kaiser and Providence and some of our competitors. And we tried to select what we thought were the best practices in each of those programs. And we are covering now what we call a personalized care support program that ensures that all of our members, their physical, social, and spiritual needs are at the center of a care delivery plan. We cover advanced care planning, we cover home health visits, we cover in-home counseling for individuals, families, and caregivers, and like Aetna, we provide specialized case management services from qualified nurses and social workers. I apologize for being over time, but I really thank you for your participation and for remembering that healthcare is personal, and we're blessed to do this work because it's going to make a real difference for the American people. Thank you.